Welcome back. In this lecture we're going to look at the management of diabetes, and the PowerPoint that you've got available on the system, you'll notice has 53 slides. The first 36 relate to type 1, type 2, what it is, and the hope is that that's some sort of revision for you. We're not going to go through that on screen. What we're going to focus in on is the actual management of the condition. So it's worthwhile, if you haven't done so, to pause the film now and read through and refresh your memory of your understanding of the drugs used to treat, the two types of diabetes, because we're now going to move on and focus on the treatment of diabetes. The two things that we are looking at are going to be the oral antidiabetic agents excuse me, and the insulin therapy. If the insulin is not there at all, or is very, very low, you will need insulin therapy. If the insulin is present but not acting properly, then you'll take an oral antidiabetic agent. The oral antibiotics are picked 5 classes. We've got the sulphonylureas, the Prandial glucose regulators, the Biguanides, the alpha-glucosidase inhibitors, and the Thiazolidinediones. Or TZDs, people often say, otherwise your false teeth will fall out. Let's start with the sulphonylureas. These are drugs that are taken once or twice daily, and what they do is they stimulate the cells in the pancreas to make more insulin. So therefore, it's not that the pancreas is unable to make insulin, it's just not making enough. And these drugs make the pancreas create more insulin. And they also affect the insulin to work more effectively in the body, so they overcome insulin resistance. So they've got a double-edged attack. They can cause some significant side effects. They can cause nausea, gut upsets, increases in weight. They can cause a rash if there's an allergy to it. What you've got to watch out for, though, is they can cause the glucose levels to drop so low. If you boost the insulin response too much, then you'll actually lower the glucose to such a level that you cause hypoglycemia. So in the treatment to avoid hyperglycemia, you can get the backlash of hypoglycemia. Got some examples there of the sulphonylureas, and this is just to let you see an example of all the different drugs that are out there. And you'll see that they've got different doses, different dose ranges, how much you take in a day, etc. So you just take a second, pause the film if you like, and just read through and look at them all. The ones at the top that I've put an asterisk beside are probably the most common ones that are used. Clopropamide is probably one of the big players in this area. The second batch are the Prandial glucose regulator, taken 3 times daily. And they work by, again, stimulate the pancreas to produce more insulin. And they're taken when a meal is consumed. So you're taking them 3 times a day, so you're probably taking them breakfast, lunch and dinner, would probably be the thing to say. And you only take it when the meal is consumed. They're much shorter acting than the sulphonylureas. And because of that, you can take them with the meal. They last, if you like, to work when the glucose level in the plasma is rising, and therefore they are less likely to cause a risk of hypoglycemia. And because the dosing can be flexible, and you're taking it with the meal, and you can adjust it to suit the meal, they're less likely to cause weight gain. They can still cause the same thing though, of the gut upset, the nausea and the rash. And again, we've got the 2 big boys here for that class, the Biguanide and the Thiazolidinediones. So you'll see there the Prandial glucose regulators' names, they end in that Glinide ending. So Repaglinide and Thiazolidinediones. And I've given you the trade names of Novonorm and Starlix, and you'll see it again. Just have a look at that in your own time. The Biguanides, 2 to 3 times a day, they're taken. They help stop the liver produce so they stop gluconeogenesis, the production of new glucose, and they overcome insulin resistance by making the insulin carry the glucose into the muscle and the fat more effectively. So a bit like the first class we spoke about, they make the insulin work better, but they also stop the production of new glucose. Okay? These ones don't work to stimulate the pancreas to make more insulin in the way that the first 2 classes did. But again, stomach upset, nausea, etc., just the same. But that usually wears off and you're less likely to get the gastric upset if you take these drugs with or immediately after food. Best known example, metformin, also known as glucomet and glucophage. So again, a wee look there just to see what drugs you might encounter in this area. We then got the TZDs, taken once or twice a day, and these will overcome insulin resistance. So what they're doing is the natural insulin that's there will work more effectively. But side effects, headaches, fluid retention, weight gain, and respiratory tract infections, interestingly. So a slightly more significant batch of side effects there, but they're a newer group and they seem to work efficiently to overcome insulin resistance. So then we've got the rosiglitazone and pioglitazone. So again, you see the commonality there. These drugs, the TZDs, have the GLIT as the glitazone ending. And again, I've got a couple of trade name examples there. So if you come across them, you'll know the names that you can look out for. So those are the classes that basically say, you've got the insulin there, it's just not working well enough. Or the pancreas can make insulin, it's just not making enough. But what if the insulin's just not there and can't be made? That's when you step into insulin therapy. Yeah. And you've got different ways of giving that. You've got what they call rapid acting, long acting and short acting versions of insulin. The rapid acting, you will give 5 to 15 minutes before eating, or when you're eating, or immediately after. Because it's rapid acting, it'll work there and then with the food. And it can last for 2 to 5 hours. But probably not long enough to control the levels totally between meals, and sometimes you'll do it with a mixture of a rapid acting and a long acting. So rapid acting to get the onset immediately, long acting to keep you going between meals. The long acting, as it says, a longer acting form of insulin, it's more slowly absorbed. So therefore, it won't come on as quickly, but it will last longer. Hence the reason we said you might take a short acting to get the insulin boost that you need, and then the longer acting one will come out into the system over 24 hours. So that's only taking 20 once a day. So what you can do is you can take the long acting one and you can phase in between that your short acting ones with the meals. We then have short acting, which are known as soluble in insulin, and these work to lower the blood glucose taken just before a meal. And they only cover the rise in glucose that occurs after eating. They're not there for the day. So you might only get peak action within a couple of hours or so. They can last for up to 8 hours, but they're nothing compared to the 24-hour action of the long acting. You've also got now the ones in between, medium and long acting. And they'll have their peak activity between 4 and 12 hours, although they can last up to 30 hours. So the medium long acting, they can often go alongside the short acting. So what you do is you take the medium and long acting, they give you if you like, the stability throughout the day, and then you take the short acting at a different dose with each meal to counteract the surges that come with the meal. And that's what the mixtures are. The mixtures are combinations of short and long acting ones, taking them just before a meal that will cover the rise, and then the longer acting portion will continue to work between meals. So you're actually getting it in a single mixed combination. You don't have to take 2 separate things at different intervals. So that works pretty well. So that was just a quick overview of the insulin approach to insulin therapy. And prior to that, the oral antidiabetic agents. So if the pancreas isn't making enough, or the insulin that's been made is not working well enough, you take an oral antidiabetic to enhance that. If the pancreas is not making insulin and there's none there, you need to get insulin replacement therapy, and that's what we've talked about in the final few slides there. Thank you very much.